Hello, everybody. Thank you for coming. Just a couple announcements before we start. Make sure to join our listserv on our website. We'll have that linked in the bio, such as the email, so you know whenever we're having an event. Make sure to also follow us on LinkedIn. We post a lot on there too as well, and make sure to list us as one of your experiences on there. Also, we increased our quiz limit to 48 hours, so make sure you take advantage of that and really take your time answering our journal questions. Now time to introduce our physician today, Dr. Lee. She's a medical oncologist who is board certified in internal medicine. She currently works at Malcolm Berman Cancer Institute at GBMC. She completed her medical school, residency, and her fellowship. That's a triple crown at Vanderbilt University of Medicine. Her residency was in internal medicine, and she specialized in oncology and hematology during her fellowship. We're so happy to have her today. And without further ado, Dr. Lee, you can take it away.
All right. Well, hi, everyone. Yeah, my name is Yan Lee. I currently am a staff hematologist oncologist at Greater Baltimore Medical Center. So some of you may be familiar with that because it's right here in Towson. And this is just hopefully a brief overview of hematology oncology. So just to briefly go over an outline of the presentation, I'll talk about, what hematology and oncology are if you're not familiar with those fields, and the training to become a hematologist oncologist. And then my personal path to hematology oncology, and then try to give some closing advice and then an a question and answer session. So I'll start with what is hematology. I present with you a black box because I think a lot of people don't know much about hematology, but this is a field that is really the study and treatment of diseases that are related to blood. And so what does that include? I think that includes a lot of different organs in the body that you may not think about. Among them are, your lymph nodes, which are present kind of all over the body, as well as, your peripheral blood and the bone marrow itself. And then just to go into a little bit more detail about the bone marrow, what that comprises of, that's, the spongy bone that's inside of your long bones, and it contains multiple different different types of cells, and among them are blood stem cells, your white blood cells, your red blood cells, and your platelets, and then those go out to the peripheral blood, and that's oftentimes the things that we're measuring when we do blood tests. So to talk a little bit about some of the diseases that we see in hematology specifically, one of them is blood type, bleeding disorders. And so, that involves our coagulation pathway as well as our platelets. And so we can often see bleeding problems that we're asked to look at. And that includes diseases like hemophilia. Von Willebrand's is another one that people may know about. And then the opposite end of the spectrum, which is clotting problems. And unfortunately, there are people who have bleeding and clotting problems. And so we oftentimes get involved for those cases to figure out what's going on and really the best course of action and treatment for those patients. Additionally, we see patients who have, specific abnormalities of hemoglobin. And so this category of diseases is called hemoglobinopathies. And the most well-known is sickle cell disease, and that's depicted here. And you can see these abnormally shaped red blood cells here are the sickle cells, so the deformed red blood cells, and unfortunately that can cause a myriad of complications for which we see patients for. Other ones are like thalassemias, and then of course, even though we see these are considered benign conditions, we also see malignant hematology conditions, and these kind of ugly big cells that you see here are this is acute myeloid leukemia, which is a disease that is still quite aggressive and rare, but one that we commonly see. And then there's certainly other ones like multiple myeloma and lymphomas that we treat as well. So that kind of comprises, in a short way, the diseases that we treat in hematology. So kind of moving on to oncology, I think this is a field that people are much more familiar with, which is the study and treatment of cancer. I think a lot of times when people think about the word cancer or oncology, they kind of immediately associate that with intravenous chemotherapy given through an IV. And I try to, associate this with, what's seen in the media or on TV shows that people might be familiar with, because like at least for emergency medicine, they can talk about ER and like, there's other and scrubs, that actually focuses a lot on internal medicine and surgery, but nobody really talks about oncology. So the only things that I could look up and find, one is, I don't know if anyone watches The Undoing, that was on HBO. I won't give a lot away, but Hugh Grant's character is a pediatric oncologist in that show. And then maybe this is more well known, but I kind of forgot that Wilson was an oncologist on House, but they didn't really talk about oncology on the show. So, and I think part of that is House was like a very diagnostic dilemma show, and oncology is usually not a diagnostic dilemma. So it's kind of like, we get the biopsy and then we figure out staging and a treatment plan. So I'm fortunate. So I don't think there's like any kind of, stereotypes or reputations that oncologists have, at least from that standpoint. But I wanted to talk about, some of the really exciting things in oncology. And I think you can see part of the reason why I chose this field is that over time, what we have seen is that the cancer death rate has slowly been uh, decreasing over time. And even though on here you can see the actual number of deaths and the rate hasn't changed too much, the increase in deaths, once you standardize it for like age, like people are living longer. And so then, they're developing cancer later in life. And so that's why we're seeing, yes, the number of deaths is increasing, but the actual death rate itself is decreasing. And so that kind of goes into, and then, just to talk a little bit about the survival rate too of cancer overall. With most cancers, you can see here over time we're seeing an increase in the survival rate of really all cancers, which is very exciting and really shows how much medicine has changed over time. And I think like oncology and hematology have been like microcosms to show the advances that we've made. And so I'll talk to you guys a little bit about, how that's happened. So there's been treatments that have become available that have been very exciting. Even though, oncology, cancer, people traditionally think about chemotherapy, we now have exciting medicine that's available called immunotherapy. And the goal of that is that we recognize that, not all cancers are equal. And also that a lot of times cancer cells are quite smart and can evade the immune system. So we want to use immunotherapy, which kind of which is basically when cancer cells basically turn off your immune system, and then we can take these medicines which actually will kind of activate the immune system to fight the cancer cells. So it works in a totally different mechanism than you will often see with chemotherapy, which is just the purpose is to kill rapidly dividing cells. So the concept of them is almost the opposite, but that has really immunotherapy has really revolutionized several different cancer types, and it's still being used in clinical trials to see if how to incorporate them into therapy for people. So that's been really exciting. And then for malignant hematology, what's been really exciting is CAR T therapy, which is chimeric antigen receptor therapy. And for a lot of really resistant cancers, or specifically in hematology, we're able to remove blood from patients and then re-engineer the patient's immune system and specifically their T cells to go to be reinfused into the patient to attack their cancer cells. So that's been a really exciting and new development in malignant hematology. And they're starting to study forms of that in solid tumors as well. I think that's been a really, really exciting change overall.
Dr. Lee, I think your hand or something's over your mic. You're a little muffled.
Oh, okay. Sorry. Did you hear that last part?
No, can you repeat it, please?
Yeah. Okay. So I was just saying, so what's been really exciting is CAR T therapy in malignant hematology diseases. So leukemias, lymphomas, and recently it was approved in multiple myeloma, but it's basically taking blood cells from the patient and then re-engineering those T cells that the patient has to attack the cancer cells. And that's been really amazing and effective in a lot of patients who have really refractory disease. So it's really exciting and something that they're trying to use in solid tumors as well. And so I think you're going to see a lot of these types of targeted personalized medicine cases which seem to be really beneficial. Additionally, another thing that we've seen is that there's been an incredible number of targeted medicines that have become available as well. And this is just an example here, but this is famously called the Philadelphia chromosome. And we see that in acute lymphoblastic leukemia as well as chronic myeloid leukemia. And this basically we have medicine, and I think this guy's gonna win the Nobel Prize one day, but he created imatinib or Gleevec, and it targets this specific mutation. And so these patients have it's really revolutionized the treatment for several different types of cancers. And this is just one example. We have targeted medicines for many mutations now, which is a growing and exciting field. So, kind of to transition into that. So you can see over the years, starting from 2000, this only goes up to 2018, but the number of oncology drug approvals has been increasing over the years. And then, and this was a Nature review, and in there you can see, specifically for oncology, the number of drug approvals has been, far greater than really any other specialty that is shown. And then just to show you, this is a little bit older now, but this was a paper that was published in 2020 that really shows kind of the explosive progression of precision medicine in oncology. And that really started with tamoxifen for breast cancer back in 1971. And then, you've had so many changes over time, and new drugs that have been available. And there's been some really exciting molecular profiling studies and so forth that's been ongoing, and also getting FDA approval in the recent years, which have also helped a lot of patients. So what is kind of the pathway to get here? As was first discussed when we started this talk, well, it takes 4 years of medical school, and then internal medicine residency, which is 3 years, and then a fellowship in hematology oncology, which is another 3 years. But there are specific places where you can do oncology only or hematology only, and not to get too much into the weeds of that, but those can be, and vary anywhere from 2 to 3 years, depending on if you choose a research track or not. And then there's also the research pathway, which is a shortened pathway where you do 2 years of internal medicine and then 4 years of hematology oncology fellowship. And then there are, as medicine gets more and more specialized, there are additional fellowship tracks in specific diseases. At Vanderbilt, we do offer a thoracic oncology fellowship. And then there's also a molecular fellowship that was recently developed at Vanderbilt as well by the former, he was an assistant program director at Hopkins previously. So we're lucky to have him. And then to talk a little bit about like my personal path to all this, I started out, I went to the University of Maryland. Unfortunately, it feels like a long time ago now. I graduated in 2009. I got my bachelor's in biochemistry and in economics. I really wasn't sure what I wanted to do yet. And so I kind of just chose two different majors that I thought could really help me make a decision. And because I was still really unsure, I ended up doing a post-bac year at the NIH. And so I worked at in a rheumatology group. And so I had a chance to see some clinical trials and also, understand the process of, how to screen people for clinical trials and arranging for them to come in. And it was really interesting because, the NIH allows you to do such specific and really rare kind of diseases. And I got to study patients with rheumatologic diseases, and they were twins. And so, that's really specific. And so I saw both identical and fraternal twins, and just to understand different protein levels and everything. So that was a really great experience. And that really pushed me, that I thought that medical school made more sense to me because I was more interested in clinical training as opposed to like more of a PhD track. And so I decided to just go the clinical route. So I went to medical school. And then I did 3 years of internal medicine residency. And then I just completed my fellowship last year. And then now I've been working at GBMC for the last 9 months. So this is just to talk a little bit about, for me personally, why I chose to do hematology oncology. A lot of this was personal interest and honestly personal experience. And, when I was young, I don't think I really knew anybody who had cancer, but as I've gotten older, certainly my mom had breast cancer when I was in college, and, the statistics show 13% of women will experience breast cancer in their life. And so I think all of you at some point will know someone who's had cancer, whether they're close or not, but just seeing her go through the treatment and how things have changed and everything, I think has really solidified my personal interest in the field. There's a lot of interdisciplinary collaborations with people. I think that's been a really important thing. We don't just talk amongst oncologists. We're often talking with other specialties such as pathology, who review the biopsies to give us a diagnosis. We're oftentimes not the diagnostician. It's the pathologists who are doing that for us, and so we heavily rely on them. And of course, we talk to radiology all the time to review scans and to understand what's going on, and surgeons. And surgical oncology specifically. And then, we're really involved with palliative care, and I'll talk about that in a little bit as well. So there's a lot of collaboration that you'll see, and of course with primary care doctors and so forth. So, and then, as I touched on before, I think precision medicine is a big reason why I think oncology is and hematology actually are really exciting. And I didn't really bring this up in hematology, but even for these hemoglobinopathies like sickle cell and thalassemias, we are looking at gene therapy options and hemophilia, like, so that is really exciting. And then, all the targeted medicines that are available in oncology now too. While it's still a small percentage of the patients that we see, I still think that, the fact that we even have that available are giving people, more quality of life, and also the ability to live longer with these diseases. And we can sometimes even, move into thinking of cancer as a chronic disease as opposed to, aggressive life-ending disease, as was, kind of the case, not long before all this. Um, I think it's a dynamic field with a lot of different types of job opportunities. And I think that's really important when I was thinking about jobs. And so with that, transitioning just into the types of jobs that are available for this. So of course, for me, I'm in community practice. And so that can include in a hospital setting, which is my job. I directly work for the hospital. We are kind of like our own specialty, certainly, but we take care of the patients in the hospital, and that's nice. And there's also private practice settings, so you're in a private group, and then you have privileges at certain hospitals that you would go to. So there are other practices around the area that are more aligned with that. There's also the academic track. And so, you can do a more clinician-based tract or a more research-based tract, and then, you negotiate kind of how much you want to do of research versus, clinical time. And so you can certainly tailor it even as just a direct MD to be much more lab-based research if that's what your focus is. And you shouldn't feel discouraged from doing that even without a PhD, because I know there were several MDs at Vanderbilt that did that. But know that that's certainly an option, and you haven't written it off just because you've decided to go down the clinical track with medical school and just pursuing an MD instead of a PhD. And so, the clinician track is going to be somewhat similar to a community practice, but certainly you'll have research responsibilities and grant writing, and sometimes sitting on boards and that sort of thing. So I think that's, it just depends on kind of what you're looking for. And then there's also regulatory work that's available, which I don't think a lot of people talk about, but certainly in oncology, I think that's really interesting. And specifically, that's working for the FDA or the NIH, and that's right down the street from you guys. And so I think that's those are really great opportunities, and something to think about if you decide that you don't want to necessarily be a full-time clinician, and you're still helping people because you are evaluating clinical trials, for example, reviewing grants, and really being like the lead investigator, for example, in specific diseases that may be of interest to you. So I highly encourage you guys to think about that if that's something that you're interested in hematology oncology, for sure. And then there are people who go and work for pharmaceutical companies, and that's kind of touching on what I had said before. There's been an explosion of FDA approvals in oncology and in hematology. And so certainly, pharmaceutical companies are constantly looking for consultants as well as medical directors that can work and really, because you've had the training from the clinical side, you're able to provide a lot of insight into, what might work, what might not work, and, what makes sense in terms of, mechanisms and whatnot. So that's a lot of different, different types of settings that you can work in for hematology oncology. So I think that's really something to think about. And this is just a limited list. There's certainly other things that you can do, but I thought that was really great about this field. And then kind of for me, why I ended up choosing community practice and specifically at GBMC. I do feel like GBMC is a wonderful place, and it's really family oriented, but also like for me specifically, I was really interested in being at a practice where I could still like subspecialize. And my specific interests have always been in benign and malignant hematology. And GBMC really offered the opportunity for me to do that, and so it was hard to pass up that opportunity. And then I think again, I have supportive colleagues, and they're all collegial and wonderful, and so I've really enjoyed working with them. And we have amazing clinical trial support, and that's really important in hematology oncology because you will have patients who are really qualified, and we oftentimes will say, if it's available to you, a clinical trial is often the best, course of action for treatment. And so and we have a really great clinical trial team, and so that was a really compelling factor in my decision to work at GBMC. And then GBMC is kind of like a hybrid institute. We do have residents, and so there's medical education teaching opportunities, and so I really like that. I wasn't fully ready to completely leave the academic world, but this kind of gives me like some overlap, and so I thought that was really really wonderful. And then this is just to talk a little bit about what my typical week is like. I usually see about 12 to 15 outpatients a day. So my clinic, that's what it's typically like. And then I participate in multidisciplinary tumor boards. And so that, we have I have a spelling error, but oncology, radiology, the surgeons, the proceduralists, we have palliative care, and sometimes genetics is present, radiation oncology and pathology. So a lot of different doctors and a lot of different specialists that are present that, all collaborate together to form really good plans for patients. And so, we often talk about the clinical trials where the data comes from. So it's a really good setting, and a lot of it's a very collegial environment. So I really really enjoy that. And then we also see inpatient consults, and so that kind of depends on a day to day what I have. And a lot of inpatient consults are hematology cases, but certainly, we do see oncology cases, unfortunately, in the inpatient setting. And then medical education. So, with the residents, we do try to do some teaching, and then we do some lectures throughout the year. And so there's quite a bit of opportunity for that, which is really nice. And then also we do bone marrow biopsies. I do less of them now. I did like over 100 of them in fellowship, and so I've had my fill. But we do those in clinic as well. So those are diagnostic procedures that we do for mostly for hematology cases. Occasionally there is an oncology case where if you're concerned that the disease has spread into the bone marrow, we'll do those as well. So I wanted to kind of end the talk with like some words of advice from someone who sort of recently went through all this. I can still say that right now. I really think it's important for you all to know that the path to medicine does not need to be linear. In fact, many of my colleagues in medical school did not go directly to medical school. And I think that's happening more and more. So don't feel like the path is only like, I have to get through college, I have to go to medical school right afterwards. There's not a right way to get to medicine. I think if you need to take time off, if you want to work for a while, if you want to do something else before you commit to medicine, I think those are all very reasonable. And in fact, I often think that that's looked upon in a good light when it comes to your medical school application, because I think that I guess the idea is that you're more convinced that that's the right thing to do for you, especially if you've taken some time off. So just know it doesn't have to be linear, and it's absolutely okay. And it's also okay to not be sure. I did not go into medical school knowing that I was going to be a hematologist oncologist. In fact, I tried to keep a really open mind to start with. I, I'll be honest with you, I thought I was going to be an ophthalmologist. It's kind of like silly to think like now that that's what I would have wanted to do, but I sat in on my first surgery with an ophthalmologist that I really respected, and she's still a mentor of mine. And I really did not enjoy it. It was just, it was very micro, it was microsurgery. And I just knew in that moment that that's not what I wanted to do. And I really surprised myself, honestly. So just know that it's okay. It's okay to change your mind. There's an ENT doctor that I work with at GBMC. He did internal medicine residency first, and then realized he wanted to be a surgeon. So he did a ENT residency. So kudos to him for doing that. But just know that it does not have to be, nothing. You don't have to feel like it's set in stone and there's no turning back. Once you've gone on one trajectory. Okay. Um, and I really do think people may tell you this, but it is really important for your mental health and just general well-being to keep up with hobbies, because uh, medicine is hard. Like, none of this is easy. You're waking up at super early in the morning, getting to work, and just feeling really tired. But try to make some time to still do the things that you enjoy, because you do need time, like, to turn your brain off, and just know that that's okay. um, and if you can, try to find a good support group. I mean, especially when you're in school and in residency and in fellowship, like, you're all in this together, like, and to find people that can help you through that and help you study, and help be a soundboard for whenever things are getting tough. It's really nice to have that. And I was really fortunate to find that. And I think that that's a really important part. Just know you're still human. Like, nobody expects you to be a robot, but sometimes it can feel that way. So just know that it's important to keep that up. And really don't be afraid to ask questions. I think the more you show interest, I think the people around you and the doctors that you interact with, or not necessarily just the doctors, but the nurses and physicians assistants, nurse practitioners, and everybody else that are involved in patient care, they're happy to talk, and they're happy to share their experiences. If you just show some interest, I think that's really the most important thing. um, so that's kind of like the conclusion of my talk. So I just wanted to see if people had questions.
Yeah, so I think my first question, you just mentioned finding a good support group and kind of how important that is. And it made me wonder, you look at a lot of hardship on a daily basis as an oncologist. Kind of how do you stay sane? I figure a good support group is part of that, but
Yeah.
keep peace. Yeah.
Yeah. I think it's hard, because you're right. Like, we see a lot of patients, unfortunately, can be at the end of their life. And you can form some really strong bonds with your patients. And then you end up, you feel like you failed. Sometimes it's like, and it's like you've done everything, but their disease is still progressing. And so I often find that it's really helpful to talk to, certainly my former co-fellows. Those are the people that I'm closest to. And in fact, I'm in, just like these text chains. And so we talk about that. And, my husband is not medical. And so I try as best as I can to leave it at work as much as possible. But of course, it sometimes does spill into my home life. But I certainly don't go into details, because that would be a HIPAA violation. But I do, I just say, hey, it's been a hard day. And so he knows what that means. And, but just having, like, colleagues that you feel, like that you can talk to. And I talk to, and not to say, I mean, I talk to my former co-fellows, but I talk to my colleagues at work too. Sometimes when it's just been, you just feel uneasy or, not sure about something, I feel like everyone has had that experience. I will say that. And so it's something that kind of unites all of us as providers for patients, and so I think that, it's just it it's been good, and I feel very lucky and fortunate that I found that with my work family, and also with people that I've worked with in the past as well. And so that's I wish I had better advice than that, but I think you're kind of, with fellowship too. I was one of six, and so there's very few. It's just those six people, and so I saw them every day, all the time, and so you naturally become close, and there are shared experiences and bonds that are not really tangible that you continue on to have.
Yeah, I figured it would be a small fellowship, like you were saying, where there's only 6 of you guys, and going from an internal medicine residency to an oncology and hematology fellowship, what kind of experiences were you exposed to? And even like your colleagues, like you were saying, what were they exposed to that kind of made them decide to pursue that fellowship and specialization?
Sure. I do think a lot of it is that it's a really exciting and rapidly changing field, and the fact that there's a lot of flexibility in the job fields of what you can go into after you do hematology oncology. I think some of it is personal, like what you've experienced in the past. And a lot of people have strong relationships with their primary care doctor, but with your oncologist, you end up having, it's almost, there's this brief, if you have localized disease, it's curable, and it's treated. Or even if you have metastatic disease, it's like you have a chronic relationship with them. You see them all the time. In fact, when you're on treatment, you're seeing them like every 2, every 3, every 4 weeks. And so those are people that you might be seeing more than you're seeing your family. And so I think I wanted to have that kind of like rapport and longitudinal relationship with my patients, because there's certainly an appeal with short-term relationships, like in emergency medicine, right? But I knew I wanted to have a long-term relationship, but I still wanted to be in a subspecialized field. And so I just thought oncology really offered me that. And then hematology wise, because that's more of what I'm interested in, I find that hematology is very similar to internal medicine. There's a lot of diagnostic and investigational work that needs to be done, and a lot of interpretation of results. And I really enjoyed that part of internal medicine. And so that was a big reason why I semi subspecialized in hematology and fellowship.
I think that's really cool about the longitudinal relationship. I think a lot of people look for that and don't necessarily know how to find that. But going back to what you said about how it's a rapidly changing field, how do you personally keep up with all of that?
Yeah, so I think that's one of the toughest things that we have to do, and it's often something where you talk to colleagues, you ask for second opinions, and you do your own research. And so I would say I spend a lot of time, just kind of going over new information. We get alerts when there's new FDA approvals, and we're really involved in clinical trials. So we have an idea of what's going on in the different specialties from that perspective. And then talking to my colleagues, so in our group, and not every group is like this, but in our group, everyone kind of has their like more specialized field, but we still see all different types of diseases. And so, I have certain colleagues that I would go to if I had a breast cancer case. I have certain colleagues that I would go to if I had like pancreatic cancer, something like that, So I have that. And then I also feel extremely fortunate that I still have a good relationship with a lot of my mentors from Vanderbilt. And so it's really nice because I kind of have this additional like lifeline, and I can reach out to them and email them and be like, hey, like I have this case, I'm not really sure what to do. What are your thoughts about X or Y, or Z in terms of management? And so I do find that some of that is just like if you've had those relationships, it's nice to be able to kind of go back to that and be able to ask those questions in addition to also reading up on this yourself. And we do have this set of guidelines called NCCN guidelines, and it's accessible for everyone. And so you can actually look through that, and it kind of tells you like general, like approved, like what most people agree upon are, first line treatment or, second line treatment, and et cetera, that kind of thing. But the nuances, I do like to, I think talking to colleagues and also kind of looking up papers and clinical trials is really the best way that I found to work. So I would say I'm not like always actively like reading everything that's available, but as the cases come up, I would say, that's when I'm reviewing things and trying to get everything together to figure out the best course of action.
Right. And that goes back to when you were talking about how, when you have an available clinical trial, a lot of times that's the best course of action. How do you kind of screen that? And how do you determine like who's a really good candidate? And what does that look like on a day-to-day basis for you?
Yeah, so we have a clinical trial team, and we have meetings every 2 weeks or so to talk about new trials that are available, and then statuses of current trials that we have available. And then, we're all encouraged to bring forward trials that we find might be interesting, and so it ends up being like several different, avenues of how we get access to the clinical trials, and we're part of big clinical trial groups, and also the NIH is close by, and Hopkins and Maryland are close by, and so we oftentimes kind of I have an idea of what's available in those places, and you can always, so it's publicly accessible, but you can look at clinicaltrials.gov, and so that also has a lot of what's available for patients. So some of it is that, and then when those protocols are made, they outline specifically like exclusion and inclusion criteria. And then if you have questions, you can always email like the lead principal investigator and the team about, hey, what does this mean? Or like, what can you include? What can't you include? And we also do our own screening of our patient list. It's like, oh, okay, well, we see one patient of this with this disease like every 5 years or something. I'm exaggerating. And then like, is that worth opening an entire clinical trial for that one case? And sometimes the answer is yes, because it's really rare. But sometimes the answer is like, no, it would be really hard to do that. So kind of, it kind of just depends on the situation and kind of the stipulations of what the trial will say.
Absolutely. And, as you're saying this, it sounds like you have an active role in research as an MD. And you also talked about earlier kind of how you chose that path instead of a PhD. What are your thoughts on MD, PhD pathways that are accessible to students now?
Yeah, I mean, I think it's a wonderful path. I mean, I think if it's tailored to what you want to do, then I think it doesn't make sense for everyone, but it makes sense for people who are interested in pursuing that. And I do think it helps you certainly have a better understanding of what it's like in the research setting, like if you want to pursue that. But that's not to say not all MD PhDs end up doing research alone, and certainly not always bench research. I mean, that could be clinical trial research, in the academic setting. And, there are MD PhDs that go into the private sector as well. So it's still quite fluid. I think what you can do with the double doctor degree. I find that I've interacted with a lot of MD PhDs, and I find that they definitely think about medicine differently because they have the research background, and they've dedicated a decent amount of time to studying something really specific. So I, it because I didn't go through it, I can't say like, I know exactly, but I did do lab-based research as a fellow in oncology because I think it was just like, all right, this is like my last chance to do bench research and like really decide if I want to do clinical work or research-based work. And it was a wonderful experience. And my mentor, I can't say enough great things about him, but I also had time to self-reflect, and I was like, while this is amazing for somebody else, it's not how I see my future. And so I didn't end up doing it. But I think a lot of academic programs, if you end up there, and again, I can't, because I did everything. I can't say I'm a lifer because I obviously left Vanderbilt, but like during my time at Vanderbilt, I know they've done some really exciting things. For example, for internal medicine residency, if you're interested in pursuing a more research-based track, they do allow for that in residency now. Like you can, I think you can do a research-based track where you do like a year of research. And again, that doesn't have to be just like a lab-based research. That can be a clinical trial research project with a mentor or something like that. So I think there's a lot of programs that are kind of moving towards that. And even the Vandy Med School, I think they have a year of research built in, and same at some other institutions as well. So I think there are specific, you can tailor that to, the program that you go into. And then let's say you enter medical school and you decide, hey, I do want to do the PhD. You can do that. Several of my former med school classmates are doing that now, like later on, but like they are doing it. So it's certainly possible if you want to.
Absolutely. We have a couple questions from the chat from the audience.
Okay.
Melody wants to know, how has your day-to-day experience changed since the pandemic onset?
Yeah, so that's really interesting. I think that I think medicine's always kind of been resistant to change. I hate to say that, but it really has been. So telemedicine has been something that's been coming, but I think a lot of that was really not huge. But we really had to convert to that, because of the pandemic. And so we did convert a lot of our patients to telemedicine unless they needed to come in for like an acute care visit, or if they were getting treatment that day, something like that. So, but now, as people are getting vaccinated, and we're also still doing, still masking, doing everything appropriately, we have been allowing, letting more people come in to the office. And so I think that was really interesting, and something that I really had to adjust to, because like I started this job in the middle of the pandemic, and I didn't really know a lot of people. So I was like, oh my gosh, like I don't really know how how this is all going to work. But it's honestly like I've just had really supportive and collegial colleagues, and that's really been the most help, and everybody around me has been wonderful. And so a lot of that transition was much smoother than I anticipated.
And another question from the audience: how do you kind of tailor your approach based on a patient's age and aggressiveness of cancer? What does that look like for you?
Yeah, so I try to be very honest with my patients about what I think about prognosis. We have some prognostic scoring, charts that we can go to depending on what the disease is. So that helps patients make decisions. And that's actually one thing in breast cancer that's been a huge thing, because we actually have risk reduction scores, and so you can see, okay, well, your lifetime risk is X, so are you willing to take this medicine to try to reduce your risk of developing breast cancer, for example. And so I do think that certainly age, and also importantly is your performance status. So how well do you look, and how well are you functioning, and also part of that is your support. So I mean, it's much harder if you're alone, like by yourself, right? And you don't have like family or friends that can help you if there was an emergency. And so those are all things that we take into consideration. And we have a wonderful like support service at GBMC that helps people, get Ubers or Lyfts, to them from clinic, and also can provide, help people apply for grants, because unfortunately oncology care is quite expensive. And so we do offer those things. And so I think that I try to just be honest about, certainly side effects and, what to expect. And then ultimately, I always tell the patient, this is your decision. You can do none of the things that I say, or you can do all of the things, or you can do part of what I say. And then, we take it from there, because, and also even with treatment, it's like, if you have side effects, then we scale back, or we take a drug off, or we do something. We we have to change things. Things change as time goes on. There are unintended side effects, or intended side effects that are intolerable for people. So I think you just kind of have to take it individual, because the treatment for one person is not always the right answer for the treatment for somebody else. So it just, case by case basis.
Absolutely. I hate to keep switching topics on you, but my last question is about earlier in your presentation when you were talking about the CAR T cell therapy. Are you already using this in patients? Is it still in preliminary trials? When can you expect to be using it?
Yeah, so we are already using it in patients. It's FDA approved for several different diseases. Among them are acute lymphocytic leukemia, specific types of lymphoma, and then recently it was approved for multiple myeloma. Recently, as in like I think a week or two ago. So yes, it is being used. We do not specifically offer it at GBMC right now, but Hopkins and Maryland do, and I think some of the academic centers in DC and certainly in Virginia do offer it. So yes, it is available. It's very specific. There are very specific indications for it, so it is not a treatment that we say right off the bat that's what we give people. Patients, but in the relapse refractory setting of disease, we do consider that as an option, because it's not, it's certainly got side effects, and so I would not, like we don't take it lightly, for sure.
Absolutely. Thank you so much for answering a bunch of these questions. We really appreciate it, and for coming to present today.
Oh, of course, anytime. Feel free to reach out if you guys have questions or concerns. Unfortunately, we're not like really taking students or anything right now if people were interested, but maybe after things are getting better, that might be something. And if people want to reach out or have questions, I can put in the chat, like, can I put my email address? Will that work?
Yeah, and we can send it out over the chat also.
Okay. All right, great. Well, then I'll just wait for you guys to do that. So yeah, I'm happy to answer things. I might not get back to you immediately, but I will try to answer it in some time.
Absolutely.
All right. Well, thank you guys.
Thanks for having us.
No problem. All right. Take care.
Thanks for coming
Bye.
on. Bye.
Take care.
Thank you everybody for coming today. We dropped our quiz link in the chat. We also dropped our Linktree link where you'll find our website, our LinkedIn, and our Instagram as well. So we hope to see you guys next week for Dr. Watchmaker, a dermatology session. Again, as always, if you have any questions, make sure to reach out to us on Instagram. Have a great day, everybody.